Good evening, everyone, and thank you for joining us tonight for the Foot Risk Screening and Management session. My name is Kylie Somerville and I work at Central and Eastern Sydney PHN. I'd like to start by acknowledging the Aboriginal and Torres Strait Islander peoples of this nation. I recognise their continuing connection to land, water and community, and I pay respect to elders past, present and emerging. I also acknowledge any Aboriginal colleagues joining us today. I'd now like to introduce our presenter for tonight, Georgina Frank. Georgina is a podiatrist specialising in diabetes-related foot disease. She's currently working as a project officer for the National Foot Forward project, which aims to develop an integrated diabetes foot care pathway to support early referral for people with diabetes-related foot diseases. Georgina is currently on secondment from her usual position as Deputy Director of Podiatry for the Sydney Local Health District. Georgina also currently practices in outreach with the Outback Vascular Health Service and endocrinology team for RPA Hospital Diabetes Centre, and works with the fantastic Murray Ma Aboriginal Health Service in Broken Hill and Wilcannia. Georgina has completed her Masters of Public Health and is also the current Vice President of the Advanced Practicing Podiatrists High Risk Foot Group. So welcome, Georgina. Thank you so much for being here, and I'll now hand over to you.
Joining me today for the foot screening and management presentation based on the International Working Group Diabetes Foot Changes Guidelines, Diabetic Foot Guidelines, and the Diabetes Foot Australia Adapted Guidelines that are coming out as we speak. Okie dokie. I'm hoping this is all working beautifully. So I'm going to also acknowledge the traditional owners of the land on which I stand, which is part of the Gadigal Nation. And also I'd like to welcome elders past, present and emerging. Thank you very much for joining us. Okie dokie. So the outline of today is basically we're going to look at preventative foot care, prevention, screening, knowing when and why to refer. And for many of you, it won't be too different to what you've already done. There have just been a few changes as part of the international guidelines, some of which you'll know and some might be interesting. And there have been a few changes in how we do screening. Secondly, it's active foot disease. So I won't go into quite as much detail in treatment and those sorts of things, but we will go through with identification because these are all part of the new guidelines. Okay, so some of these things you'll already know. In Australia, we've got at least 1.7 million Australians who have diabetes, and 300,000 are estimated to develop diabetes. 300 Australians are estimated to develop diabetes every day. Of these, approximately 300,000 are at risk of developing diabetes-related foot disease, and as we speak, 550,000 have a current foot ulcer. So identifying people with diabetes who are at risk of developing foot problems is vital to support the implementation of preventive foot care strategies to encourage prevention of foot ulceration and amputation from occurring. Routine diabetes foot screening is effective in identifying those at risk of developing diabetes-related foot disease, but in Australia, our figures, now these are starting to get a bit old, it was 2003, but our current figures were about 50% of people with diabetes didn't receive their annual foot check as part of their diabetes cycle of care. And so I think the worry is that many people who present with a foot ulcer, we also diagnose them with diabetes-related peripheral neuropathy. So this is a quick little, we're going to jump out a little bit, but what is diabetes-related foot disease? So it includes everything. So foot ulcer, infection, tissue loss due to ischemia, and Charcot foot or neuroosteoarthropathy. And I haven't gone into too much detail on the actual individual diseases in this presentation, and I'm happy to go into more detail if you'd like. And I certainly haven't gone into Charcot in too much detail either, but I can expand on that if people would like. But coming back to why we do a foot screening, so we want to identify the at-risk foot, so we want to get timely intervention. We want to classify the risk of developing diabetes-related foot disease, identify the early warning signs of foot disease, allow for targeted prevention and early identification, and also provide an opportunity for self-care education, so people can help themselves essentially. And so part of that is we just want to find out what those risk factors are. So to be at high risk of developing foot disease, you've either got loss of protective sensation, peripheral artery disease, combination of both, plus any of these. So previous foot ulcer, lower limb amputation, end-stage renal disease, and deformity. And then there are a few little extras that I throw in because I am still a podiatrist at heart. So we start with what to ask, and medical history. This is the bread and butter of what we all do in primary care, tertiary care, throughout all stages of medical and paramedical care. So we're going to start with the history, and some of it, we just want to know what their medical history was. Have they had a previous foot ulcer or amputation because of diabetes? Do they get wounds that don't heal? So some people will manage a wound for a very long time without showing their doctor or their nurse or their podiatrist. Do they have renal disease? Have they had other lower limb, so vascular surgeries, so anything to improve their blood flow? And of course, smoking, past or present. All of those things have major implications to foot health. So now to go into a little bit of the exciting, sad stuff. And sorry, I do have some photos. Most of you will have seen them, and I don't think they're too awful, but I don't have too many warnings. So previous foot ulcer. So the rate of recurrence of DFU, or diabetes-related foot ulcer, is 40% in 1 year, 60% at 3 years, and 75% at 10 years. So prevention and early identification can reduce recurrence rates by 31 to 62%. Huge, it's massive, 31 to 62%. But we do find that people who've had one foot ulcer will normally get another one, and their 5-year mortality is 40 to 50%, which then worsens with end-stage renal disease. So then we get on to previous amputation. So mortality after diabetes-related amputation exceeds 60% at 5 years for all people with diabetes, and 74% at 2 years for those receiving renal replacement therapy. So there's huge implications to someone's quality of life. And in Australia, our amputations, these are non-traumatic, is 4,400, which is huge and pretty shameful for us at the moment. And of course, end-stage renal disease has just been added to the risk stratification pathway. Adults receiving dialysis who have peripheral neuropathy and a previous foot ulceration are at the highest risk of developing foot ulcers generally. And people with diabetes on renal disease are therefore at particularly high risk. Sorry, I've repeated myself. This is a lovely picture of one of my podiatrists, Sarah. We visit all of our dialysis services in Sydney Local Health District, so RPA and Concord. And this is one of our gorgeous patients who subsequently has had a renal transplant, but unfortunately his neuropathy hasn't improved. And so we still see him regularly for his foot ulcers, but not as much because he has great footwear. Anyway, we're going to go on to what to look for, which is also what to test for. So it's a bit of a combination. A huge thing that we try and do in Diabetes Australia was every 2 years, take your socks off. We try and encourage all of our patients to take their socks off whenever they see any of their physicians or carers within who look after their diabetes, or without if they want to frighten them. But important to remember that the presence of diabetes-related peripheral neuropathy or peripheral artery disease affects, at least 1/3 of people with diabetes, increasing the risk of diabetes-related foot disease. So this is still the major concern. So when we go through the pathway, if you have peripheral arterial disease or peripheral neuropathy, you're already at risk of developing foot disease. So we now call it low risk. If you're at very low risk, you have no risk factors, but low risk indicates that you have at least PAD or peripheral neuropathy. So diabetes-related peripheral neuropathy, So it's the leading cause of diabetes is the leading cause of peripheral neuropathy. Diabetes-related peripheral neuropathy is a condition that affects the peripheral nervous system, especially the ends of the long nerves, such as the toes and the feet and the hands, but toes and feet first. Important to remember, it's highly predictive of ulcer risk. It's our main reason you will get a foot ulcer. So it can be present at diagnosis. It can occur without symptoms, which is why it's sneaky. Severity is related to duration of diabetes, poor glycemic control, and height. So the taller you are, the more likely you are to have some sort of peripheral neuropathy. That's length dependent, and we've got no real treatment to reverse it. Excuse me. That's in just the wrong spot. Bear with me. I had issues with my computer today. So diabetes-related peripheral neuropathy is characterized by or associated with sensory neuropathy. Now, we find this really important because the symptoms of sensory neuropathy are loss of protective sensation. So people lose the ability to protect themselves. And that means, oh, no. Sorry, I thought that was a question.
No.
So many people who develop sensory neuropathy often have no symptoms and don't know they've got it. So you've got loss of pain awareness, inability to feel hot or cold, pins and needles, burning sensation, shooting pains and numbness. And that tends to be more at the beginning of the process. Absence of these symptoms does not rule out sensory neuropathy, which is why we have to still test. But sensory nerve dysfunction means that people may sustain an in-foot injury without being aware of trauma or damage leading to ulceration. Motor neuropathy, so dysfunction which can lead to gait changes, so the way a person walks, which leads to mobility problems, like risk of falls. Foot deformity, and this is where foot deformity becomes a problem. So if you don't have peripheral neuropathy, foot deformity actually isn't that much of a problem, but with because of the foot deformity that's caused by neuropathy, so you get a high arch with claw toes, pes cavus, or the change in foot shape results in an increased pressure under the metatarsal head, so the forefoot, results in abnormal hard skin. So you can sort of see how all of these things start combining to cause a foot ulcer. Oh, come back. Sorry. Oh, flip. Sorry. Computers hate me. So when these all combine, you've got a foot that is just ulcerate because you get abnormal hard skin, callus, which then causes the underlying tissue to break down and ulcerate. And then you've got autonomic neuropathy. So that's nerve dysfunction, which causes diminished sweating, resulting in dry, scaly skin. And that contributes to callus formation, which then is prone to fissuring. So you get those deep cracks. And the fissure enables bacteria to enter, resulting in clinical infection and ulceration. Now, painful peripheral neuropathy isn't quite part of the development of ulcer, the sequelae, but it has such an impact on quality of life. So people can have loss of peripheral sensation, but still have painful peripheral neuropathy, not just in that early stage. Excuse me. Oh, I don't have Rona. But the symptoms can include shooting, burning, tingling. It's worse at night, but not with exercise, and it can be minor or cause considerable pain. We recommend all our podiatrists make sure we refer on to either their GP or if we work with an endocrinologist for management, because quality of life is so significant. And the absence of any of the symptoms doesn't rule out sensory neuropathy. Because then I'm going to come back, do a little back slide. So the thing that we're testing for is loss of protective sensation. So diabetes peripheral neuropathy causes loss of protective sensation, and it's the single most important risk factor in foot ulceration and amputation in people with diabetes. So that's what we're testing for. So even though diabetes causes peripheral neuropathy, more a symptom of it. So the test for loss of protective sensation. So within the guidelines, monofilament touch test and tuning fork have been recommended. In clinic, we use neuroanesthesiometer to test vibratory sensation. However, within a clinical environment, we recommend using the monofilament. So 10-gram monofilament, the Sims-Weinstein touches has the very high degree of accuracy. But if you don't have a 10-gram monofilament, the 128 Hertz tuning fork test can be used. It's reduced vibratory sensation, may also predict some increased risk for ulceration, but we tend to only recommend using it if outcomes from the monofilament test or the light touch test, which I'm not going to go through today, but I can send you the information, do not show loss of protective sensation. So coming back to it, we test 3 sites. Most people, there are lots of different ways that people have been using. I think some are 10, some are 20, but the international guidelines consensus has been to use 3 sites, which you can see under the big toe, under the first MPJ, big joint, and the 5th MPJ, the smaller one. Now I'm going to try a video, which was very unsuccessful earlier, but we will see if it works. So these are my lovely colleagues, Anna and my diabetes nurse. Anna's a podiatrist who runs the high-risk foot service at RPA, and Molly is her wonderful diabetes educator. And so it's really important to explain to the person what you're going to do and to show them that you're not going to poke them with a very sharp implement, which some of them think it is. You've got to make sure that they shut their eyes. So you want to ensure that they can't see what you're doing, where or when you're doing it. So you apply the monofilament perpendicular to the skin surface with sufficient force to cause the filament to bend or buckle. Now, duration is we always think of it skin contact and removal of filament. So it's about 2 seconds all up. Now you press the filament to the skin and you ask the patient where they feel the applied pressure. So they're the 3 sites, and you ask them whether they say yes or no. So if I put it under the first MPJ, so under the first joint, I will go, can you feel it? And then I take it off. And if they can feel it, they tell me, and I might ask them where, which just gives me a little bit more information. Now, 2 of those tests are going to be legitimate, but the third one, or one of them, is a mock one. So you will ask them, can you feel it without touching the skin? And most people will say they can. Now, we assume that they've got protective sensation if at each site they can feel at least 2 out of 3 applications, and absent with the mock. You'd be surprised how simple it is. It's actually working really well with our non-English speaking patients, which is why I think consensus was really important, because it was international and it worked with a lot of different countries. And it was less confusing, but it is slightly different to the way we've done it in the past. It's taken us a little while to get used to it, but it's actually working quite well. Feel free to ask any questions. But moving on to peripheral artery disease. So some of this you guys are definitely going to know, but I'm just going to reinvent the wheel a little bit. So atherosclerosis, which I can't even say today, occurs when there's partial complete obstruction of one or more of the peripheral arteries, aorta, iliac, or the lower extremity. It affects 22% of the population over 75, 20% who are symptomatic. 20% of the people who are symptomatic have diabetes. But we have to remember that with loss of protective sensation, they don't feel claudicating pain. So we think the numbers are a lot higher. Now, as PAD progresses, the development of systemic, you'll get with the development of systemic atherosclerosis. I'm so sorry, my pronunciation's awful today. You've got chronic limb-threatening ischemia, which is a new term for so it's a new term for someone who's got a foot ulcer with PAD. So chronic limb-threatening ischemia manifests, and it's defined by the presence of rest pain, tissue loss, or gangrene, which are limb-threatening with a high, because it has a high mortality and poor quality of life. Importantly, people with peripheral artery disease may also indicate the involvement of coronary cerebral and renal vessels, leading to increased risk of myocardial infarction, cerebral vascular event, and death. So if we're managing people, especially from Sydney Local Health District, we'll often just in our preventative care clinic, so good old nail care, we always make sure we update our GPs, especially if it's unknown, because we know that the risks are higher for these people and it's more of a global risk. So it's that more holistic risk. Now, really importantly, and this might surprise you, or it might not at all, but PAD on its own is rarely the cause of a foot ulcer. It's usually the combination of diabetes-related peripheral neuropathy and trauma, which leads to ulceration, and PAD then complicates that healing. So in Australia, 50% of people with diabetes and foot ulcers have underlying PAD. So it's always worth knowing. And it comes back to just knowing your medical history. So history of smoking, duration of diabetes, hypertension, all of those things will all have combined to affect people. And also we want to focus on whether there are modifiable risk factors, so things we can reduce that cumulative risk. Now, screening. So I'm going to bang on again, history of symptoms. So claudication or reduced walking. But as I said, just to be really confusing, if they've got peripheral neuropathy, they might not have claudicating symptoms. And of my people in my clinic, I've only got about 3 that have true claudicating symptoms, even though that we work at Concord with a fabulous vascular team. But we also have handheld Dopplers, which I will go into. Rest pain, similar problems. People rarely feel it. Excuse me, that's my fault. Dad. Sorry about that. I do apologize very much. So the other thing is rest pain, which people find really hard, especially our students find very hard to understand what rest pain is, but it generally happens at night. It's the forefoot and it's relieved by dependency. But if you've got neuropathy, very rarely do our patients feel it. But getting a history of previous intervention is a nice little shortcut. So if people already if they've had a bypass or they've had an angioplasty, it's a really nice idea to find out whether they've got, it's a nice way to delve deeper and assume that there are going to be some problems. And of course, it's observations. You can often tell that a foot is ischemic. They've got cool toes and feet. So you test both feet with the backs of your hands, or if you've got a thermometer, use it. Absent hair growth, so consider your people. So I come from a very Eastern European background and there's no absence of hair, whereas my best friend's Filipino and has divine legs. So, and it's also dystrophic skin and nails. So the nails aren't getting enough blood flow. So, and the skin just starts to devitalize. So it's not great. Now, the other thing is we're looking at pallor on limb innervation and dependent rubor. So dependent rubor is the fiery or dusky red coloration visible when the leg is in a dependent position. And then when it's elevated, it all drains off. Now you test for it by positioning the patient flat and elevate the legs 60 degrees for 1 minute. And then you examine the sole, so the bottom of the foot. Now, PID causes the sole to change from pink to pale in fair-skinned people, but it's more grey or ashen if you've got darker skin. So it's really important to know who you're looking at. But the faster the pallor appears, the worse the PID. We don't tend to recommend capillary refill much anymore unless someone's really poor. And it's more that it's going to take 5 seconds or above, and then we get quite worried. So these are all really important, really simple tests, but it's always take your socks off. So having a look at those feet. So just reinforce, we're looking at dependent rubor, pallor, and then it's palpate pulses. So I've got a little video. So this is from the Foot Forward modules. So we've got modules online on diabetes foot risk screening, which are RACGP, and you get your CPD points. So I'm just going to send this through. This should have sound, and we'll see.
Assessing foot pulses. Palpation of lower extremity pulses will identify abnormalities indicating peripheral arterial disease and the level of involvement. If the dorsalis pedis and tibialis posterior pulses are impalpable, the presence of PAD is highly likely, as more distal tibial arteries are most commonly affected in patients with diabetes. If either of the pulses are present, it is unlikely that there is significant ischemia. Pulses are either palpable or they are not. Pulse assessment by foot palpation. The dorsalis pedis is palpated on the dorsum of the foot, lateral to the extensor hallucis longus tendon, between the first and second metatarsals. The posterior tibialis is palpated by cupping the calcaneus, the heel, and placing the fingertips below and behind the medial malleolus.
Okay, so you might have noticed a few issues with the animation, but because of COVID, we couldn't get real people. But often when you're trying to get posterior tibialis, it is cupping the heels, but you're trying to get pretty much that whole space behind the medial malleolus. And look, I think a lot of people do come through and speaking. So they often say, oh, but it's not very, there's a high inter-observer variability and all of those concerns. But we do find if you're doing it in an unhurried clinical setting, diagnosis has been shown to really accurately diagnose PAD. But if you are concerned,
assessing foot
handheld Doppler. So most podiatrists tend to have a handheld Doppler now, or a lot of clinics now have a handheld Doppler. They're very, very accessible now. And it's, in a way, it's quite simple. And I've actually included, so I've got a Dropbox at the end. We've got a decision tree on when to refer on. But with our handheld Dopplers, as long as you've got a good triphasic arterial waveform, we can assume that they don't have PAD. So if it's nice and strong. However, if it's monophasic, we definitely want to, there's a definite indication there's some sort of peripheral artery disease, and further studies should be reviewed. So you should be looking at doing vascular studies. So arterial duplex, ABI is still the recommended way to diagnose PAD, even though we know that calcification will elevate those elevate the brachial index. But if you've got an ABI of less than 0.9, high sensitivity and specificity that there's a presence of PAD. Any result above 1.4, you can assume it's abnormal and it's just calcification. So then we tend to move on to things like toe brachial index or duplex ultrasound imaging. So whenever we get an ABI, we always ask for waveforms, because sometimes our ABIs with our patients are elevated, and it is good to know exactly how much blood's getting down there, especially if I'm about to debride a wound. But the nice thing, the rule of thumb is if a person has an ABI of 0.9 to 1.3, toe brachial index of 0.75, which more services are now doing, or triphasic pedal pulse, that waveforms, they're unlikely to have PAD. So this is a funny little slide, but it always comes in because it's usually one of the questions that we get asked when someone does say, my feet hurt. And these are the three things that, a little bit of a rule of thumb, we tell people to think about. So if it's ischemic rest pain, if it's worse at night and it's relieved by dependency, we associate it with signs of PAD. So if there's an association with other signs, so their pulses are bad, or their symptoms don't, their feet look bad, or they look like they've got PAD, and it's predictable, so they know when it's going to happen, we can assume it's more rest pain at night. Because neuropathic pain, it's usually bilateral, doesn't get better if you hang your legs down. You've got a wide range of sensations, so shooting pain, pins and needles, and those sorts of things. If it's musculoskeletal, which I'm now feeling as I get a bit older, it's morning stiffness. It usually happens with exercise or at the end of the day. It's reproducible. So when I have you sitting in my chair, I can cause it again. And it's usually in a specific location. And this brings me to my little bit of a shout out with critical limb ischemia. So it's not really related to the PAD that we're worried about. It's usually because the thrombosis has been thrown off or something similar. But the quicker you send someone in to get it checked, the better their outcome. So usually, and it's obvious, I think a lot of people would have seen at least one in their lifetime. We've had a couple, but the foot is very white. Doesn't matter what your background is, and they can't feel. So someone who would have been able to feel can't. If I get them in and get them checked within 6 hours, it's reversible. The longer it takes, the less, the outcomes are worse. So it's always worth having keeping that in the back of your mind. Okay, so we're now on to skin assessment. Did anyone have any questions? I can't actually see the chat at the moment.
Nothing in the chat at the moment, Georgina.
Great. And look, I think a lot of this is going to be, people are going to be quite aware of it. So pretty pictures. So when you're getting someone's socks off, these are things we're looking at. So we're looking for foot wounds and lesions. That's the big one. We're all trying to see that between the toes, top and bottom. We're also looking at skin color and temperature changes. So skin color changes, as I said, we could be just looking at for peripheral arterial changes. But of course they can just be fungal, or if you've got significant temperatures, it can also be a Charcot. Or it can be just good old infection. Callus and Corns is the other one we're looking for. It's a nice modifiable risk factor that we can do something about in most cases, but it also can indicate that someone's got pain that they can't feel. So they're developing abnormal callus and corn. And abnormal is usually there's some sort of hemorrhagic callus there, and they don't feel it, and they should. Skin cracks, autonomic neuropathy, but also we can get really skin cracks plus fungal infection. Some of our highest admissions for cellulitis at Concord are from interdigital breakdowns, which then become infected. In a way, they're quite easy to clear up, with IV antibiotics. But if people have very good, foot care, self-care, and we keep an eye on those things, the problem wouldn't happen. Deformity. So in the whole context with neuropathy, deformity is a problem. Deformed nails. Even though deformed nails are not a cause of foot ulcers in most cases, unless there's PAD, they're painful, and quality of life is quite significant, and it can affect mobility. And then you've got swelling and edema. So lymphedema is undermanaged in most countries, but Australia as well. So catching it early and referring on very quickly is very important. But also for me, Charcot, it's one of our first. If you've got something that doesn't improve, and it's not infection, there is a temperature difference, but it doesn't improve with elevation, and there's significant redness. We can have up to 6 to 7 degrees temperature, doesn't improve with Lasix. A lot of people put on Lasix or antibiotics. Charcot should be a consideration if they've got peripheral neuropathy. Now we go into a bit more detail. So we want to inspect all people with open wounds. Now, it's the most important finding. If you've got a foot ulcer, it's the main condition you're screening for, and it's present with people with diabetes at risk, markedly increased risk of amputation, and referral to a multi-disc service is recommended, or just getting on to treating it quite quickly. So, you know, the guidelines say if it hasn't healed within 4 weeks or improved by at least 50%, that's when you refer on, because a lot of these will heal quite quickly once you're aware of them in primary care. Excuse me. So if you want to check all people for these sorts of calluses. So we call them pre-ulcerous lesions, and that's the new definition for people that have neuropathy or diabetes. They occur in areas of chronic high pressure. It becomes pathological when LOPS interferes with normal preventative behaviors, so loss of protective sensation. Generally, a podiatrist can refer it. So this one you can sort of see that it's got hemorrhagic callus at the top, but also there's a lovely area that looks blistered, and that went right through to the joint. And it's often, we then try and we'll debride it, but it's the actions to reduce recurrence, which is the most important thing. So it's changes to footwear, it's foot orthoses. Those therapeutic footwear and orthoses is the most proven way of keeping people ulcer free. It's also the hardest thing to implement long term because the shoes are often quite expensive and they're hard to convince someone to wear all the time, especially when they can't feel there's a problem. And then also we're looking just at advice, you know, very simple things. So it's a lot of self-care, preventative care. And we also want to inspect all people just for blisters and fissures. So it's the inflammation and fissuring that happens with fungal infection, autoimmune neuropathy, or lifestyle choices. So if you've got someone who is a little bit larger, wears sandals, and it's quite dry, you tend to get a few more fissuring in their heels, but also just what people can afford. So where I go out to Broken Hill, it gets up to 40 degrees out there. There's no way I'm going to convince people to wear enclosed shoes. So we look at different ways of having sandals and things that are more appropriate and slightly more supportive. But I think it's important that all these factors increase the risk of secondary infection. So it's the cellulitis, which then ulcerates. And so sometimes it is, you want to refer to a podiatrist, or I've capitalized it, for debridement or of callus. So sometimes that will work. Depends if there's PAD involved, peripheral arterial disease, that is an added bonus. So we always do worry. But we do want to keep an eye on things. So this gentleman came in with it probed right through to calcaneus, but he just thought he had callus. So we want to manage those wounds and support them. Because with loss of protective sensation, people don't know they've got the infection, but if they've got PAD, and 50% of all our foot ulcers, someone's got PAD, reduces tissue viability and protection from tissue damage. And I'm going to bang on a little bit about fungal infection. So tinea pedis, it can lead to secondary infections that can be treated. So they respond well to topical treatments and good hygiene. And I'm not talking about nail, I'm talking purely about skin. But if it's long-term or severe, people do require systemic treatment. And toenails are the same. There are lots of contraindications, but the outcomes can be really significant. And I suppose the last one, I'm just go back over the fissures. So it's definitely neuropathy, walking barefoot, thongs and open back sandals. So we do try a lot of that's trying to change people's behaviors, but also can indicate that someone has physical limitations. So they can't actually get down there to put cream on. So sometimes it's working out ways to help themselves, or seeing if carers can get involved. And now deformity. So you do want to inspect all people with diabetes for deformity. Now, deformity is not a strong predictor of diabetes-related foot infection, but once you add that peripheral neuropathy or loss of protective sensation, it is. So you just add a shoe that they can't feel, which causes a blister, they keep wearing it, you'll get a foot ulcer. So most podiatrists are trained to prescribe shoes if indicated. So not everyone does need a special shoe, but we do have, there is access to programs where you can get funding, NDIL. There are a lot more layers now. So we have state funding, we've got national funding through My Aged Care and NDIS. So things are becoming a lot more complex for people to access these sorts of things, but we do have very skilled pet orthotists and shoe people in, especially our district, but also in Australia. And then lastly, it's really important to consider Aboriginal and Torres Strait Islander people. So they're over 4 times more likely to have diabetes than non-Indigenous people. I don't know how I did that. And it's an overall incidence of 13% and rates as high as 42% has been reported in some remote communities. They're also more likely to experience a 3 to 6-fold increase in foot complications. So they've got loss of protective sensation, or this includes diabetes-related foot disease. It's a younger age of onset. Hospital admissions are higher and lower limb amputation is higher. And the figure is higher in some states and territories. And this should be, you know, I think it's really important to remember if it's 5 times more likely in NT, non-territory, but they also live for a lot longer, live further away from services. But Indigenous Australians tend to develop diabetes earlier and they have diabetes for longer, so they get more complications. So it's really important to consider cultural safety when conducting a foot assessment. And the guidelines tend to suggest that you should assume someone with an Aboriginal and Torres Strait Islander background they are at risk until they're assessed. So once they've been assessed, then you review them every 12 months if they're very low risk. But until that time, we do recommend assessing everyone through the door. I think everyone should be assessed, but anyway, that's me. So now we get on to a little bit of a break in the system. So we want to determine risk. So the new guidelines are, if you're very low risk, you've got no risk factors at all. If you're low risk, you've got loss of protective sensation or PAD. And then you get onto moderate risk, which is loss of protective sensation or PAD with foot deformity. And then you're high risk. And these things all contribute to how often someone should be reviewed. So if you're very low risk, it's every 12 months, but then the guidelines have increased referral and review times for people depending on their risk level. So if you're at low risk, it's 6 to 12 months to rescreen them. As you get into moderate, it's 3 to 6 months. And then when that's high risk, it's 1 to 3 months. That doesn't mean that they have to see a podiatrist every 1 to 3 months. But it does mean we try and encourage our people to take their shoes and socks off to at least be reviewed to make sure that there are no foot wounds. And it's trying to include everyone in the system. So with our Aboriginal health worker program, it's working with primary care. So the Aboriginal health workers become involved. Now, this isn't in New South Wales because it's our state. We're slightly different to the rest of the country. But as an example, we have health workers that then do the foot checks every 1 to 3 months and feedback to the primary healthcare team. But it's working out a plan within your practice and trying to, I suppose, demystify or desensitize people taking their shoes off or getting family members involved. So, it becomes that whole process of getting everyone involved. I think the other really important thing is that the guidelines, but I think just generally, so most education now doesn't actually focus too much on people who are at very low risk. You give them information on protective self-care behaviours, but there's not been much evidence to suggest scaring people with the outcomes that I see, particularly help people who are at very low risk. So focusing on education tends to be for people once they get into that low, moderate and high risk. So I always say why and when to refer to a podiatrist. I think not everyone with diabetes needs to see a podiatrist. If you've got normal foot toenails and you're low risk to moderate risk, low or very low, particularly very low, you might not need to see a podiatrist because you can cut your own toenails or you've got a family member who can do it safely. But safely is the big thing. So if you've got someone who's low, moderate or high risk and you're concerned, putting them into linking them in with preventative foot care is very important and can significantly help them. It's not the be all and end all. There are lots of, I think the guidelines are really clear that even though we said podiatry referral, there's also a caveat saying someone who can provide foot care. So that can be a range of different people. Any registered person can cut toenails, essentially. Podiatrists, that's just more bread and butter. And tend to have more of the kit available. But I think that's just getting someone who's involved with supporting and protecting their feet long term. And it's usually, I think one of the big things is you're just catching something before it becomes a problem. So that would be that's the regular review. And I suppose the other things that we try and get everyone to address, and this is based on the guidelines, is enacting a foot action plan. So you want to review and enact a foot action plan with that person based on their identified risks. So the PHN, and we've developed some really simple little guides. So if you assess someone at being at very low risk, it outlines the really basic things that you've found and recommended pathways. So someone's very low risk, but they've got really nasty toenails and they can't cut them, they might need to be referred on. You're just not referring them on because they're going to lose a foot, essentially. So people should still be referred on. And these little summaries can help. So I've got them all in our Dropbox. No, it's not a question. So the other thing is always review footwear. And I will go into some really simple things because not everyone's going to be an expert in footwear. But as I said, it's our main way of keeping people healed. Structured foot care education. And structured foot care education is, I suppose, look, I think most people in this room will agree that education has changed somewhat. So we now are not going through a whole lot of education all at one space. It's just reinforcing education and bringing things up at most appointments and not overwhelming people with too much information, which I think is really hard when you've got a 15-minute appointment and you're expected to manage their entire health. So sometimes it can be just spreading things out, or if you've received a letter from the podiatrist that has said, I've told the person to wash between their toes, it might be that's the only thing. It's just making sure we're all on the same page and everyone's saying the same things. And then definitely in most people's wheelhouse is optimizing their diabetes management, including modifiable risk factors, which I know is your bread and butter, but it's also organizing referrals and recall date for rescreening. So every district's a little bit different, and Southeast Sydney, they'll be sending me their details as well. And I think things have become a lot more complex with My Aged Care, NDIS, and what's health and what's not. But most podiatry services, we're all sort of equipped to try and help sort people out or help organise people, even if they don't if some of the districts don't see anything, because most of us are risk-based now. And during COVID, we are very risk-based at the moment. So most hospitals in Sydney Local Health District, because we can't major COVID hospitals at the moment, we're not even allowed to see people for preventative care at our hospital sites. So we're having to reorganize things quite significantly and use our community centres a lot more. So COVID has been a real pain, but we are tending to all work together quite well. And our patients have been really fabulous and picking up, gosh, telehealth brilliantly. So now I'm going to get on to footwear. And I suppose the main thing I'm going to say is most injuries or ulcers, 50% are caused by ill-fitting footwear. And that can be just thongs, but it is our most effective way of reducing ulcers, but it's also our best way of giving people ulcers. And people will always tell you that they're wearing their best shoe and it feels great, but if you've got lots of protective sensation, you don't know. So we all are aiming for protective footwear that prevents foot ulcers, reduces pressure under the foot, and helps falls injury and prevents common foot problems. Simplest way to think is we want to try and get a shoe that resembles the foot as much as possible. And I think that it can be somewhat disappointing, especially primary care, after people have seen a podiatrist and the person comes back with a somewhat inadequate shoe. Sometimes we try and do baby steps and try and move people out of a particular type of shoe into something that's slightly better as we slowly move on. But we have wonderful modifications that we can do to quite a few shoes. And I think the important thing to do is we always ask people what shoes they wear, maybe bring them in, but we also ask them what they wear at home, because people always wear their best shoes to see me. And then when I actually then see them, we actually see the shoes they wear around the house or in the garden, because people don't want to wear their best shoes in the garden, but they can spend hours. The shoes can be quite terrifying. So the other thing is we always want to look at the shoes. You want to just make sure it's hygienic and intact, and there's no nail coming through the bottom. So a nice good rubber sole is fabulous. You want lace up or Velcro fastening, and there's got to be enough room for the toes. I think most people know the thumb width from the longest toe is always worth it. And we also want to make sure the foot doesn't bulge over the shoe. Enclosed heel will protect and enclosed toes will protect your feet. Not always possible, but there are now sandals that have really nice backs to them. And we want leather or breathable uppers, so the top should be breathable, and they are getting much better and more affordable. Sports shoes tend to be a favorite, which is hard, especially with older people who don't want to look like they're about to go on a marathon, but there are shoes coming out now that incorporate the best things about shoes. Cushioning is really important, but remember, cushioning in these shoes only lasts for about 18 months if they wear them all the time, which is difficult. And I suppose the biggest thing, if they've got a foot deformity, they might need special shoes. Just have there's nothing to see. So they're the main footwear things. Now, education, we've tried to keep it really simple because it's really hard. I think if we trying to change behaviors through education is very, very difficult. I think we're getting better at recognizing where we're not doing such a good job and we're trying to improve, but we are getting there. So I suppose the thing is you want to individualize your education and try and remember that amputations are preventable. So a lot of people come in once they've been diagnosed with diabetes, and a lot of people have stories of family members that have lost a toe. So it's really essential for the person with diabetes to check their feet every day. If they can't do it, we ask someone else to do it. So if they've got retinopathy, they might not be able to see their feet. And we want people to look between their toes. And if there are any changes or problems, it's getting that help really, really quickly. The other thing is you want people to have really good hygiene, like washing your feet. And it's not as easy as it sounds. If you're unsteady in the shower, we try and get people to use a shower chair, but sometimes they don't fit, or they're waiting on someone, some changes, modifications to be made. So we try and work out other ways that they can clean their feet or apply cream afterwards. So education really aims to promote self-care knowledge and protective behaviors, and enhance their motivation and skills. So I work with a wonderful diabetes educator who, in the context of having diabetes, hundreds of things that you have to know and keep an eye on. You almost have to have a medical degree to keep an eye on your blood glucose levels. And there are so many more medications now, and you've got Libres, you've got all these flash monitoring. So there are lots of things to do. And you're also looking after a family, and you're also looking after yourself. We try and, whenever we see them, we try and change one thing. And sometimes it can be simply whereabouts if you had to put cream on your feet every day, where would be the one place that you would remember to do it? And so we really try and start really simply. And then I think the big one is addressing common pathways. So we talk about the footwear, we talk about preventing burns. If you've got loss of protective sensation with summer coming up in Australia, we're going to start getting people walking out onto concrete, or if they decide to go to the beach, and getting lovely 3rd-degree burns. And we also, so part of that is avoiding injuries from not wearing shoes. So it is big, a bit of a juggling act. But the other thing is you want to seek help early, even if it doesn't hurt. So people say, oh, my GP is really busy. I think most GPs don't mind having a look. We always tell them your GP is not going to mind looking at your foot. They really don't mind, but our patients are really gorgeous in many ways, or they just don't want to know. So it's trying to get through that information timely. And this sort of brings me to health pathways and Sydney local health intake criteria. So this is just to give you an idea of how, even though we are very risk-based, so you can see these are the decisions that we make about how we're going to see people. There is always capacity within our district to see people who have a foot pathology but no diabetes, but also older frail people that need foot care. So unless they've got, so we can see a number of people who are community, so my aged care packages. The problem is the hospital tends to not see people when they start to get into the 3 and 4 categories. So there are little things that we don't have much control on. So the home packages tend to be something that we have to work out. NDIS is very difficult as well for people to understand, and we all try to work together. But if everyone's got a foot ulcer, it doesn't matter. And it doesn't matter what their background is, where their funding's coming from, we see them regardless. We've got a lot more freedom, but we never discharge people unless we know where they're going. But for every district, Health Pathways knows exactly what we all do. So if you go through Health Pathways, you can see that. We were involved with developing the COVID pathway for high-risk foot as well. Sydney Local Health District took a massive lead for the whole state. So it also incorporates some of the pathways that have been adapted for each district, because each district's different. So as you can imagine, Liverpool and Westmead have almost closed their books to high-risk foot and pretty much any preventative care, because everyone's gone, they're just drowning a little bit. Whereas if you go to the northern districts, it's business as usual for the Hornsby area. So Health Pathways does sort of take those things into account, or at least give you contact details. So I always recommend going through there. And we've all got, it'll have all of our links, and also you can always email us, because we all have email now. Now, does anyone have any questions they want to ask about the preventative foot care? I'm going to assume no, and there's no chat. We can always say stuff at the beginning, especially if anyone disagrees with me, feel free. The other component of the integrated diabetes foot care pathway is active foot disease. So this is change from the old one. So as you can see, some of the terminology's changed. So we've now got acute limb ischemia, chronic limb threatening ischemia, which I mentioned before, and foot ulcer, and the pathways to referral have changed as well. So if it's no infection with a superficial ulcer, so if not greater than 50% reduction by 2 to 4 weeks, you refer. The national recommendation is to refer to a high-risk foot service or something similar. So depends what's available. And it's as you go higher when you refer. Oh, I think we've got a quick question. I'll come back a little bit. So Rebecca's just asked, hi, Georgie, is it common practice to ask a person with sensation loss about falls? Look, it is for us to ask, because it's a major cause of falls. It doesn't always have to be, it's not always something that we can change or fix, but appropriate footwear can help. And non-COVID times, we have some really good programs like Stepping On, which provide people with, I don't want to say alternative, but ways to mitigate those problems. And some of it is just convincing some of our older patients or younger patients to use aids like walking sticks or frames. So I have a lovely man who's only 36. So he's got loss of sensation without diabetes, but because of other causes, and got a nasty Charcot as a result. So he's got a big foot deformity, gets for ulcers, but he also has falls. So he's very unsteady, and we had to work quite hard with our physios to get him to use an aid. So we do ask, and the recommendation is to start considering those sorts of things. I hope that helped. And now, sorry, back to active foot disease. And so the other thing is we've gone a bit more into Charcot as well, and there's action plans on when to refer. And the really important thing, and remember, this is a national pathway. So I know in remote areas, acute limb ischemia was a very big problem, because people were worried if we said refer immediately to ED, it means that we'll have to call the flying doctors. Unfortunately, you do. Unless we get people in very quickly, they'll lose a leg. And some of the referrals, if you refer to the vascular specialist, so chronic limb threatening ischemia, it's more just making sure you put the referral through. It doesn't mean that someone has to be seen within that day. And some of the high-risk foot services have vascular teams associated with them. So it's always worth having a chat and knowing your area. So this is a national pathway. And of course, severe infection, you go to ED. And if you've got moderate, we've broken it into mild and moderate infection, depending on where it is, because it might depend on where your referral is going to go. So for mild infection, oral antibiotics are usually fine. But once you get into those moderate infections, you might have, depending on their complications. So if they've got PAD or they're very unwell, just generally, they might need to go to their emergency department. So there are lots of different things. And the suggestions are for the practice points, and that is basically the standard of care. And I will go into that into a little bit more detail now. Before I jump into that one, I'm going to just say with Charcot, if you've got someone who you think has a Charcot foot, immobilizing it is immediate. So if you can get them into a prefabricated walking cast, even from a chemist or a local physio, even if it isn't that, you can actually reduce deformity until they can see their podiatrist or their high-risk foot team or the orthopedic surgeon who manages it, depending on where you are. Worst thing is they're a bit they're uncomfortable for a couple of days. But if it is a Charcot and not infection or something else, if it really is a Charcot, you can really reduce the risk of deformity developing. But we'll come back. I will remind you all, foot ulcer infection and tissue loss and referring on. So I'm going to stick to foot ulcer in this one, partly because this is where, especially for our district, but Charcot actually fits in. So as I said, more than happy to go over it later. But it's sort of knowing when to refer and why it's recommended that you go through a high-risk foot service or a similar service. So depending on when you are, so wound care services are similar, community nurses, we all work together. So diabetes-related foot ulcers are complicated and can be challenging to address. And a systematic method for management of DFU requires an understanding of its many causative factors. So we want to know why. And this is available in primary care as well. So it's just knowing what you can do. So sound knowledge of appropriate assessment procedures, therapeutic treatments, or having an accepted pathway for referral to make sure you can get comprehensive management. Standard of care, which most of us will know, will be addressing infection. So there are 6 principles essentially. So your access, you want to address infection and give me one sec. Make sure, so infection is the biggest thing. The quicker we get onto it, the better we can treat it. We also want to score the ulcers. So part of the pathway, the international guidelines, which has been endorsed nationally as well, is to use a scoring system. Sinbad has been recommended. So you're looking at site, infection, neuropathy. You're basically looking at ways of quantifying the ulcer so you can see if it's healing, whether it's improving, and it also makes it easier to refer it on. And I can send you more information. The other one is local wound care. So sharp debridement, ulcer dressing, and 6 principles of ulcer treatment is you want to have access to offloading and ulcer protection. So this can be offloading devices like non-removable casts, so total contact casts, prefabricated walking casts, customized healing shoes, but it also includes access to trained staff, orthotists, and podiatrists with experience in offloading and protecting ulcers, access to vascular intervention to restore vascular perfusion. And I suppose the other thing, I'm just going to jump back to infection because I didn't speak about it very well, is knowing that you can always contact the hospital ID teams and microbiology if you need further treatment, or a lot of the hospitals now hospital in the home, so you can refer to the infectious disease teams via hospital and home who can implement IV antibiotics and provide support. They accept care referrals, especially Concord and RPA, accept referrals from primary care. And of course, back to my local wound care, so that's sharp debridement by trained staff and access to advanced wound care modalities, access to metabolic control and holistic management. So we want to optimize glycemic control, malnutrition, edema, and comorbidities. And a lot of people that do come with an ulcer, they will often present to a primary care without having been seen by those primary care physicians, and they'll be diagnosed with diabetes at the same time. So most high-risk foot services have links in with either diabetes diabetes, orthopedics, and vascular teams who can provide that support as well. And the other thing is we can reassess every 2 weeks, at least every 2 weeks. And that's the same in primary care, because you just want to make sure that everything's improving. And we go through the steps to converting a chronic wound to an acute ulcer. And I put this in mainly because, I was having a few issues. We get a lot from everyone, including patients, that you made the wound bigger and it's bleeding and it looks worse. Look, it is the commonest question that we get in high-risk foot services and podiatrists from patients and other healthcare practitioners. People want to know why we convert a chronic wound to an acute wound. So sharp debridement reduces pressure, stimulates the edges of the wound, and releases growth factors and reduces inflammation. But it also just removes dead diseased and infected tissue, and it allows healthy tissue to grow. And it eliminates conditions for bacterial overgrowth and other disease processes that can lead to pain, sepsis, and eventually amputation. And the other thing is it allows wound dressings to work better. So Ergo Clean and Start, which are the only randomized controlled dressings, they depend on a clean wound bed to work. Even Ergo Clean, which does help remove slough, works better if slough has been removed by sharp debridement. Or some of my colleagues, especially in the States, during COVID have been using maggots extensively because they haven't been able to get out because they've been completely shut down. So there are lots of different ways to debride. Some of the dressings are debriding tissue, they'll debride as well. But the whole point of all of our debridement is that they have to have a good vascular supply. So if they're ischemic, it's not safe to debride until you've got clearance from vascular team. So we don't tend to do any of those things. They've got a full foot ulcer. We generally are starting to put people in contact casts. So you might see that because healing is much improved. But otherwise for frailer patients or people we can't convince, we have them in healing shoes. Not as good, but they do work. So I think the biggest thing is we want a wound to heal within 3 months. So, oh man, I don't know why that keeps doing that. So, not 12 months, 12 weeks. So, ulcers should heal within 12 weeks. It reduces the risk that you're going to get bony involvement, reduces the risk of amputation. So, we tend to make sure, that's just me reinforcing what I've said. There's an RCT of sharp debridement across 10 centres, 118 DFUs. And the authors reported that foot ulcers were treated at centres that derided more often had better healing outcomes. So debridement is really key, but we don't do it more than once a week because we still need the wound to heal on its own. And that's really all we're doing. Now, this is just to reinforce that we do not debride, and that includes using a gel dressing. So we don't even use gel dressings if there's severe ischemia, even if we don't. So until we can have it, we are convinced that there's enough blood flow to heal, or if it's an unusual wound. So we've had a few melanomas, so people who've been sent to us who've had ulcers for quite a long time. We're lucky that we work with a dermatology team at Concord who will come and biopsy for us. But if you've had a wound that's been there for a very long time, and I'm talking, we've had people 6 months and the wound just hasn't healed, we will usually biopsy or get dermatology to do a review. For some people, it's just too painful. So we're not everyone we see has diabetes or loss of protective sensation. And so coming to us isn't really indicated. There's not much we can do. We do use topical MLAR, local anesthetic, but that's not always appropriate for everyone. And I suppose the other reason, if you don't have the skill and knowledge to debride, you probably shouldn't if it's not in the right place to debride. So we don't tend to debride in people's beds or if we can't get them into the chair because it puts people at risk. And also if people refuse. So people are allowed to refuse to be treated and they choose to have conservative management. The other thing is if they don't have enough antibiotic cover, we won't do it, especially if they've had a heart valve replacement. So there are main reasons. Now get back to the grading of a foot ulcer. So we recommend this for everyone, and it is being recommended. Wounds Australia, we're also recommending it as well. So it's a classification system that helps in identifying likelihood of healing, developing a treatment plan, assisting communication and monitoring treatment and predict possible outcomes. So within Australia, the high-risk foot surfaces tend to use Texas Wound Foot Ulcer Classification System and Wi-Fi. So Wi-Fi is hard to do in community because it depends on being able to do toe pressures and depth, and it's much more detailed, whereas Sinbad has been specifically invented, I'm going to say invented, for community. So we use it in our community services, and it is recommended for primary care. So Sinbad System uses 5 clinical features: site, area, ischemia, neuropathy, bacterial infection, and depth, and it's graded as either present or absent. Now it's got a maximum score of 6. So if you get a score of 3 or more, that's associated with an increased time to healing and eventual failure to heal. So if you've got someone who's just not improving, we tend to recommend referring on, and we keep that in our centers. So we've got we work in our community outreach, which is usually Canterbury Hospital.
Sorry. I've got a meeting now.
8:01. How come you're zooming?
I think we might have to get people on mute. That's all right.
Did anyone have a question? Is that why you've come off mute? Otherwise, if you're just listening, could you just go back on mute so we don't get the background noise, please?
But yeah, Sinbad's a great system and it's really easy. So our community centres, we're at Marrickville and Croydon as well. And some of our people there really hate coming into the main hospital for treatment, or they're just being monitored because they're more for, we call it palliation. So people that we just keep an eye on them and refer them to vascular if things flare up. But it is a way of us keeping an eye and seeing how, making sure that things are moving along, because if you're seeing the same person weekly, you might not, or fortnightly, you might not actually notice a difference. Other things, so sharp debridement is always coupled with offloading. This is major. So we have we have total contact casts, removable knee casts, healing shoes, chairside devices. So we put people in temporary orthoses. But the other thing which we love telling people is to use a wheelchair or sit with your feet up. And we get our lovely Professor Twig to actually prescribe it if people aren't listening to us. So we do tend to try and get people to do nothing which interferes with their diabetes management significantly and just their ability to do anything. But we do say that if you're going to put your foot on the floor, you have to wear one of our offloading devices. And as you can see, there are lots of different things. We use felt to foot. We'll put felt in an offloading shoe. That felt's 12 millimeters thick, and we sometimes make it 24. So we do quite a lot of things. But every offloading device that we use depends on ulcer site, their mobility, and their cognitive state. So whether they can, what's safe for them. And so sometimes we've developed materials where we actually discuss with people that this choosing not to go into a cast, or if we can't put you in a cast, we might have to assume that the ulcer won't heal as quickly, or our outcomes might not be as good, but it doesn't mean it's always the wrong decision. And this one's a lovely picture, and I suppose I always put it in because it's just, this is what it's a little bit like in the clinic. Oh, flip. And it just sort of reinforces how complex life is. So people with diabetes and for ulcers tend to need a team-based approach, whether in primary care or whether in tertiary care or quaternary care. So in our high-risk foot service, as an example, we provide specialist podiatrists that look after the foot and implement our advanced wound healing modalities and offloadings. And then we've got medical governance for infection, but nursing and medical support for diabetes management is important, as their control is affected during times of stress and infection. So we sometimes have to change their diabetes regimes. We're using a lot of flash libres at the moment to try and assist our patients in better management, especially while the foot ulcer is playing havoc with everything else. Psychosocial support is very hard for us to include, but we do utilize our other allied health professions as often as we can. So psychology and social work as required, because we try and be as holistic as we can. But I think, as with everyone, it is really hard to access generally. So it tends to be that whole, but our referring GPs and nurses, we tend to work very closely with them, and we usually try and work out something that works for everyone, but it does tend to be, we think of our multi-district team as not just the people working in the clinic, but everyone around us. And I suppose the other thing is surgical intervention. It's not always a failure. So with our orthopedic surgeon, Mark Horsley, we try and do salvage. So sometimes removing, if they've got a fifth toe ulcer, or a second toe ulcer, or they've getting transfer lesions, they lost a big toe and it's now on the second toe. We sometimes do recommend things like a transmetatarsal amputation, because it's easier foot to shod, so it's easier for us to offload in a shoe, less likely of reulceration because it's a better foot. or we just take little bits of the foot, or we do bumpectomy. So if someone's had a Charcot foot and they've got a great big bump under their foot, we just shave off the bone that's causing the problem. And I say just, all surgery is major, but we do try to remove or reduce deformity that contributes to the ulcer. And of course, vascular, it's a huge part of our teams. So both of our hospitals, we're linked in with our vascular teams, because unless we've got blood flow, and we will send people usually for an ultrasound if their ulcer has not, even if our Doppler says everything's fine, if the ulcer hasn't healed within 4 to 6 weeks, to get more formal studies, if nothing's improving and everything's perfect. So we tend to work really closely with those things. Our ID clinics are really important, infectious diseases, which we're very lucky are now engaged in all of our teams. RPA, they come once a week, and at Concord, we work closely with our Heath Hospital in the home, but everyone's a little bit different. Diabetes is a complex disease. So, I went a little bit quickly. So we do have time for questions. But I'm just going to go through a few summary slides now, so it's not quite finished. So just to reinforce, for diabetes-related foot ulcers, debridement's the standard of care for foot ulcers, but also all of our bread and butter is you take a history before you do any debridement, because you're looking for ischemia, infection, anticoagulants, and heart valve replacement. You want to consider your skills and suitability of the setting that you're doing all these things, and objectively assess for clinical response. Basic. Our high-risk foot services are a little bit different. So Concord's a much smaller service that's podiatry run, but we also see people without diabetes, which does make things a little bit open. So we've got people with spina bifida and other diseases that aren't restrictive to diabetes, because diabetes tends to be one of the accesses for most hospitals within the Sydney Local Health District, but not all. We accept email through email communication as well as phone calls, and we have a fabulous vascular team run by Dr. Sarah Aitken, who come once a week, and Arvi Surivashni is our endocrinologist. So we have a really wonderful team. Our only contraindication of people we don't see, we tend to not see people who are palliative. So unless we can actively make a difference, so if we can't debride or properly offload, we will usually refer on to our wonderful community nursing colleagues, who are usually included with all our patients anyway, unless they can't go. And as I said, things have changed a little bit during COVID, but we can still see all people with foot ulcers. So referrals are all accepted, and we will see people. There's a little bit of a delay because everyone has to have a negative swab before coming into the hospital. RPA is a little bit different, so it's more regular. Our clinic days are Monday, Wednesday, Thursday, and you have to have diabetes because it's a diabetes foot clinic. And as with both of them, we're ulcers below the ankle, but very similar, and it is run by Professor Stephen Twigg. And similarly, if it's a palliative or an ulcer that we can't do much about, we don't tend to do too much. We're not really a dressing clinic. I suppose that's the difference. And now just back to my diabetes foot risk and stratification and triage. I can't emphasize how important it is for clinicians throughout, anyone working with people with diabetes or just generally in doing a foot risk assessment, and assessing people's risk of developing foot disease so that we can get timely intervention, and try and reduce amputations, which are completely reducible. Because we are getting better at treating these things. If you go to footforward.org.au, there are more detailed modules, so foot risk modules, but also peripheral arterial disease in relation to foot ulceration and peripheral diabetes neuropathy, 2 little extra modules which were developed with experts from around Australia, if you want to have a little bit more detail and get some good CPD points. And some good handouts as well. And it's also, the nice thing about the site is there's a little, you can plug in if someone's got LOPS or deformity, and it'll spit out what their risk is if you are interested. So thank you. Oh, I will do one last thing. We've also developed with the PHN, which wasn't really part of this presentation, but we've got we've developed a really lovely, which I can share at the end, little pamphlet on how to help someone else cut their toenails. So if you've got someone who's at home, bedbound, and their carer needs help with cutting toenails, we've developed a lovely little presentation. And also people that don't generally need, to go into a podiatrist or don't need home visiting care, we've developed a nice little guide on to help people help their family or carers to help their charges. So yes, I think that's about all. I'll stop sharing, sorry.
Thank you so much, Georgina. It was such a fantastic presentation, so comprehensive. There was one more question in the chat.
Oh, yeah, sorry.
Which I now can't access because.
Do you have a checklist we can use? I do. Yeah. We've done, I've just put together, assessment resources. So part of that is foot screening steps. So this is actually just the one from Foot Forward. So it just goes through, and it's based on the 3-minute check that was done by Armstrong in the US, but we've just applied it to Australia. And it just gives you the basic steps to go through it. And then if we go back, I've given the monofilament instructions as well. So all of those ones are in there, but the vascular pathways. So this is a really lovely tool, which I think you should see if I can make it a bit bigger. But it basically, the biggest question that most of my students have, medical and podiatry, is if you've got a biphasic waveform, it's indefinite. So they do tend to recommend referring on if you're interested, if you wish. But if it's a normal result, it just goes through the really basic pathways. It also includes things like capillary refill time. It's usually 5 seconds. We should be worried, but they should also be lying down flat. So there are a few things, little tricks and tips on explain when you should refer on. So that's quite a nice one. And I will go back and hopefully I have put it all in. So these are the screening scores that I was talking about. So if you've got someone who's very low risk, just gives really basic information, how to keep your feet healthy, little tick box on where they can get more information. And then as you go into low risk, it goes through into a few more of the risk factors. So really basic things to remember and tick box on little things. I've told you to wash your feet every day. Don't wear thin-soled slippers, and then slowly increases as it goes through. And links into the risks, basically. Of course, gets redder and scarier. And here's the providing foot care. And I think, of course, I haven't uploaded the checklist, but I will put that through as well. But here's the how to cut someone else's toenails. So it's a nice little pamphlet as well. So that's through the PHN. I'll just do a double check. And here's the checklist. So it's a little bit small, but it just goes through all the things you're checking. You don't have to do everything. If you haven't done Doppler or ABI, you just don't fill out those things, but it gives you little tips on when to refer on, basic skin and nail problems, where they've got, active foot disease, high, moderate, low, and when to refer on and how often to see. And then it also includes the pathways. So that's really about it. I will stop sharing and stop talking. So has anyone else got any other questions?
Again, thank you so much, Georgina. And yeah, as Georgina just said, if you do have any questions, then please send them through. I'll send through the Dropbox link with all those resources that Georgina just showed you.